So still some people are coming. Make it fast. So today we are seeing neurotransmitter amino acids, biogenic amines, and aminoacidurias. These are associated with the already previously covered sessions. So amino acids as neurotransmitters. So you know what are amino acids? Amino acids are the basic building blocks of proteins, polypeptide chains and proteins. And what are neurotransmitters? I think you had seen in physiology, most of the topics are covered. Even we had seen in biochemistry also. What are neurotransmitters? So neurotransmitters are chemical messengers within the brain that allow communication between nerve cells. Okay? So these are the neurotransmitters. So now we are going, there are different type of neurotransmitters, but now we are going to see what are the amino acids which are acting as neurotransmitters. Okay. You know all these presynaptic and postsynaptic neuron, all the neurotransmitters are released, everything you know. So this is here in this picture you can see the presynaptic neuron and postsynaptic neuron, and the neurotransmitter will be present in vesicles in presynaptic neuron, and they are released and they make the sodium channels, the ion channels to get open. The neurotransmitter will be entering into the postsynaptic neuron. The ions will be entering into the postsynaptic neuron. Okay, so in this way there will be neurotransmission, and the release in neurotransmitter, after releasing, some part will be reutilized and some part will be deactivated by the enzymes. So here you can see some part of the neurotransmitter released is again being recycled into the presynaptic neuron, and some part will be degraded by the enzymes. So what are the amino acids acting as neurotransmitters? Tryptophan. Tryptophan is the amino acid which is useful in the synthesis of the neurotransmitter serotonin. Tyrosine. Tyrosine is another amino acid which is necessary for the synthesis of epinephrine, norepinephrine, and dopamine. We had seen all these synthesis of epinephrine, norepinephrine, dopamine from the phenylalanine tyrosine. And glutamate. The glutamate is an amino acid which we will get from the glutamine. We know glutamine comes from the liver and all from the muscles. Then we will get glutamate from the glutamine. So this glutamate is necessary for the synthesis of neurotransmitter GABA. Okay, gamma aminobutyric acid. So these are the important neurotransmitters which are synthesized from amino acids. And apart from that, the amino acid glycine directly acts as neurotransmitter. There are many neurotransmitters, there are a number of neurotransmitters, but we are discussing about the neurotransmitters which are being synthesized from amino acids. That means these amino acids are acting as neurotransmitters. So this is a very important topic, and we had almost covered most of the things in the previous sessions. How we'll get serotonin, how we'll get the catecholamines, that is epinephrine, norepinephrine, dopamine from tyrosine, and how we'll get GABA from the glutamate. All these topics are covered in the previous sessions. So coming to the synthesis of the neurotransmitters from the amino acids. See here you can see in the first column the synthesis of serotonin from tryptophan. We know tryptophan is converted to 5-hydroxytryptamine and we'll get serotonin. Or 5-hydroxytryptamine. Serotonin is also known as 5-hydroxytryptamine. And coming to the catecholamines, the neurotransmitters which are synthesized from tyrosine, We know tyrosine is converted to DOPA, and from DOPA we'll get the dopamine, norepinephrine, and epinephrine. Okay, so these are the neurotransmitters synthesized from tyrosine. And coming to the glutamate, we know glutamate we'll get from the glutamine, and glutamate is converted to GABA, which is an important neurotransmitter. So all these metabolisms we had seen in the previous sessions, and what are the enzymes required and what are the key enzymes, all these we had already covered in the previous sessions. So this is no need to discuss in detail about the synthesis. We will get serotonin from tryptophan, and we will get the dopamine, norepinephrine, and epinephrine from the tyrosine, and we will get GABA from glutamate. Okay. So coming to the individual neurotransmitters, serotonin. Serotonin is also known as 5-hydroxytryptamine, 5-HT. It is involved in emotion, sleep, appetite, and memory. It is secreted by neurons of the brainstem and argentafin cells of gastrointestinal tract. So this is a neurotransmitter which is secreted from argentafin cells of gastrointestinal tract. That is very important clinically, because the production of serotonin from argentafin cells is associated with some disorders. So coming to the degradation synthesis of serotonin, we know the synthesis of serotonin, how it is synthesized from tryptophan. So no need to discuss about that. And coming to the degradation, this 5-hydroxytryptamine or serotonin is degraded to 5-hydroxyindole ester acid. Okay, so aldehyde hydroxylation takes place here, and that's why in any defects of serotonin, in any disorders, clinical disorders of defective serotonin, the 5-HIAA or 5-hydroxyindole ester acid is estimated in urine to confirm whether there is any excess production or decreased serotonin. Carcinoid syndrome is the disease associated with the serotonin. We know argentafin cells of gastrointestinal tract produce serotonin. So these argentafin cells sometimes grow locally into malignant argentafinomas. So these generally grow in the small intestine or appendix of the gastrointestinal tract. And the symptoms of this carcinoid syndrome are also known as argentafinomas. The symptoms are flushing, sweating, intermittent diarrhea, fluctuating hypertension. So these are the symptoms of carcinoid syndrome, which is also known as argentafinomas. This is named because it is produced from argentafin cells, which are present in the gastrointestinal tract. And this carcinoid syndrome most commonly occurs in the small intestine or appendix of the GI tract. So this is about the serotonin. So next, coming to the serotonin is produced from tryptophan and it is degraded to 5-HIAA. And coming to the neurotransmitters produced from tyrosine, they are epinephrine, norepinephrine, and dopamine. So all these syntheses we have already seen in the previous sessions. Epinephrine, coming to the epinephrine, epinephrine is also known as adrenaline. This is a very important neurotransmitter. So epinephrine is a neurotransmitter secreted from adrenal medulla. The strong emotions such as fear or anger cause epinephrine to be released into the bloodstream. So this is very important. Whenever we are having strong emotions, epinephrine levels will be increased in the blood. These are also known as fight-flight hormones. You have already seen in physiology. So this increase of when we get strong emotions like fear and anger, there will be increase of epinephrine in the bloodstream, and this increase causes an increase in heart rate, muscle strength, and blood pressure. And this epinephrine also increases glycogenolysis and stimulates lipolysis. So this is important biochemical aspect. It increases glycogenolysis. That means release of glycogen from the liver, and it stimulates lipolysis. So how it increases glycogenolysis? So here we will be seeing. We had already seen in the previous sessions by dealing with the hormones, mechanism of action. So epinephrine, we know it will activate adenylate cyclase in the plasma membrane. Adenylate cyclase is present in the plasma membrane. This is activated by the epinephrine, and it becomes activated adenylate cyclase. So this adenylate cyclase will act on CAMP, and the CAMP will in turn activate protein kinases. CAMP dependent protein kinases are activated by CAMP, and these protein kinases will deactivate the glycogen synthase. So what happens is glycogenesis will be inhibited, and which in turn indirectly increases the glycogenolysis. So in this way, epinephrine is increasing the glycogenolysis and inhibiting the glycogenesis. Okay? By inhibiting the enzyme, by inactivating the enzyme which is required by glycogen synthesis. Then how it is increasing the lipolysis? Almost in the similar way. In lipolysis, see epinephrine will activate CAMP, which in turn activates protein kinases. Here the protein kinases will activate the lipase, hormone sensitive lipase. So that's why when the hormone sensitive lipase is activated, lipolysis will be increased directly. Whereas in case of glycogenolysis, it is indirectly increasing the glycogenolysis, and it is directly increasing the lipolysis by CAMP, by activating CAMP by activating the adenylate cyclase. So in this way, epinephrine or adrenaline increases the lipolysis and glycogenolysis. Coming to the norepinephrine or noradrenaline, we know we'll get the norepinephrine from dopamine. From dopamine, we'll get from tyrosine, we'll get dopa. From dopa, we'll get dopamine. From dopamine, norepinephrine, and from norepinephrine, we'll get epinephrine. So coming to norepinephrine or noradrenaline, it is a neurotransmitter secreted from adrenal medulla, just like epinephrine. And norepinephrine is important for activeness, emotions, sleeping, dreaming, and learning. It causes blood vessels to contract and heart rate to increase. And norepinephrine plays a role in mood disorders such as manic depression. Almost epinephrine and the norepinephrine, they having same actions with little difference. Coming to the dopamine, dopamine will directly get from dopamine. Okay, tyrosine, dopamine, dopamine. So dopamine functions as neurotransmitter mainly in the brain. Dopaminergic signaling is associated with reward motivated behavior and motor control. So in a neurotransmission, which is required for the reward motivated behavior and motor control, occurs due to the presence of dopamine. So dysfunction of dopamine system leads to numerous diseases, and we know in treatment of Parkinson's disease, dopamine is used. Okay, so this is about dopamine. And what about the synthesis and degradation of epinephrine, norepinephrine, dopamine? We know synthesis of epinephrine, norepinephrine, dopamine. We had already seen the previous sessions, and we had already seen in the previous slides also. So coming to the degradation of these catecholamines or epinephrine, norepinephrine, dopamine. We know dopamine is converted to epinephrine or norepinephrine, and this epinephrine or adrenaline and norepinephrine or noradrenaline are converted to metanephrine and normetanephrine. These metanephrine or non-metanephrine are converted to VMA, okay, vanillyl mandelic acid, and this VMA is excreted in the urine. So, in the disorders associated with the epinephrine, norepinephrine, dopamine, the VMA levels are measured in the urine, okay, to see whether the degradation of epinephrine or norepinephrine is proper or not. The VMA levels are measured in the urine. Okay, so this is about the synthesis and degradation of the catecholamines. Coming to the GABA, it is synthesized from glutamate. So gamma aminobutyric acid is an inhibitory neurotransmitter widely distributed in the neurons of the cortex. It inhibits neurotransmission in the brain, calming nervous activity because it is an inhibitory neurotransmitter. So GABA contributes to motor control, vision, and many other cortical functions. It also regulates anxiety. So different neurotransmitters participate in different functions. They will affect different functions of the brain. So we are seeing all those. So GABA also regulates anxiety. And GABA is synthesized from glutamate. So how it is synthesized and degraded, that will be seen. See here in this pathway you can see glutamine. We will get glutamate from the glutamine. Okay, glutamine is converted to glutamate by glutamate synthase. Okay. And we know glutamine, we will get glutamine from the liver and muscles. Glutamate from the liver and muscles will bring the ammonia in the form of glutamine and all those urea cycle and all those we had seen. And this glutamine is converted to glutamate, and this glutamate is converted to GABA by glutamate decarboxylase. So by decarboxylation of glutamate, we are getting gamma aminobutyric acid. So that is the synthesis of GABA. And coming to the degradation, the enzyme transaminase acts on GABA, by which the GABA is converted to succinate semialdehyde. So the succinate semialdehyde, by action of the enzyme succinate semialdehyde dehydrogenase, is converted to succinate and it is recycled to the citric acid cycle. Okay. So glutamate we are getting from the glutamine, and from glutamate we are getting the GABA. And GABA is degraded to converted to succinate semialdehyde, which is in turn converted to succinate. So this is the synthesis and degradation of the GABA, okay, which we are getting from the amino acid glutamate. So these are the manifestations, or these are the clinical disorders associated with the GABA deficiency. So that's why in clinical practice, in most of the psychiatric disorders, the GABA will be given as treatment. Additionally, the gamma aminobutyric acid medication will be given to the patient suffer from the following diseases. Okay? Insomnia, depression, mood disorders, excessive stress, and epileptic seizures, ADHD, panic disorders, like psychiatric disorders. In all this GABA is given. And apart from the psychiatric disorders, also in the hypertension, atherosclerosis, and this low levels of digestive enzymes, also GABA is given. So GABA is a very, very important neurotransmitter which is useful very clinically. So glycine is an amino acid which directly acts as neurotransmitter. It is inhibitory neurotransmitter in the brainstem and spinal cord. It participates in a variety of motor and sensory functions. It affects cognition, mood, appetite, digestion, immune function, pain perception, and sleep. So all these are affected by the glycine, which is an amino acid acting as neurotransmitter. Okay. So this finishes the amino acids acting as neurotransmitter or neurotransmitter amino acids. So we have completed the amino acids acting as neurotransmitters. In that, we have seen the important amino acids which are acting as neurotransmitter. They are tryptophan, tyrosine, glutamate, and glycine. And tryptophan acting as neurotransmitter by synthesizing serotonin. And tyrosine is acting as neurotransmitter by synthesis of the catecholamines, the epinephrine or adrenaline, norepinephrine or noradrenaline, and dopamine. And coming to the degradation, synthesis from tyrosine, coming to the degradation, they are degraded into the VMA. And coming to the degradation of serotonin, it is degraded to 5-HIAA, 5-hydroxychlorotic acid. And coming to the glutamate, we will get the GABA, and GABA is degraded to succinate semialdehyde, which is converted to succinate, which is recycled to citric acid cycle. And we had already seen the different effects of the neurotransmitters. And glycine, which directly acts as a neurotransmitter, it is an inhibitory neurotransmitter. We know glycine is the smallest amino acid. So these are the important aspects of the neurotransmitters, amino acids acting as neurotransmitters. So coming to the biogenic amines. What are biogenic amines? Okay, we had already covered these topics, but we are correlating with the previously covered sessions. So biogenic amines are produced from amino acids by decarboxylation. By removal of the carbon dioxide from an amino acid, we will get the amines. So biologically important, so biogenic amines. So here you can see the amino acid by the action of enzyme decarboxylase, carbon is removed in the form of carbon dioxide, which leads to the formation of biogenic amine. Okay. So remember, biogenic amines are nothing but they are amino acids after removal of carbon dioxide. Decarboxylated amino acids are biogenic amines. So what are the important biogenic amines that are present in the body? Okay, they are dopamine, serotonin, histamine, putrescine, cadaverine, thyramine. So there are many biogenic amines, but these are the important biogenic amines. So out of these, dopamine and serotonin, we have already seen in the previous slides. The remaining of the histamine, putrescine, cadaverine, and thyramine. So coming to the histamine, we are getting histamine from decarboxylation of histidine. Okay, histidine is an amino acid, we know it's a basic amino acid. So we are getting histamine by the decarboxylation of histidine, because we know all the biogenic amines we will get from the decarboxylation of amino acids. So similarly, we will get the histamine by the decarboxylation of histidine. So this is how we will get the histamine from histidine by decarboxylation. The enzyme required for this is histidine decarboxylase. And coming to the degradation of the histamine. So histamine is degraded to methyl histamine and methyl imidazole ester acid and imidazole ester acid. In this way, the histamine is synthesized. So histamine is synthesized from histidine amino acid and it is degraded to methyl imidazole ester acid and imidazole ester acid. So what are the functions of histamine? What are the effects of histamine? What is the physiological role of histamine? So contraction of smooth muscle tissues of the lungs, uterus and stomach. This is a very important aspect. And dilation of blood vessels, which increases permeability and lowers blood pressure. And stimulation of gastric acid secretion and stimulatory effect upon the neurons. So all these are the important effects of histamine. So coming to the putrescine, it's a product which is formed from decarboxylation of ornithine. So here you can see ornithine on decarboxylation is converted to putrescine, an important biogenic amine, and ornithine decarboxylase is the enzyme required for that, and carbon is removed in the form of carbon dioxide, and for this pyroxide phosphate is needed. So this is the synthesis of putrescine. So coming to the effects of putrescine, foul odor of putrefying flesh is due to the biogenic amine putrescine. The foul odor that we will get from the putrefying flesh is due to the formation of putrescine. Spermidine and spermine are synthesized from putrescine by addition of S-adenosine. And this putrescine, apart from this, it is used in textile industry and for mechanical parts in combination with polyamides. This is the non-medical use of the putrescine, and it is used in pharmaceutical and agrochemical applications. So that is the important aspects of putrescine. The important thing, the clinical thing, the medical thing that you have to remember is the foul odor of the putrefying flesh is due to putrescine, and spermidine and spermine, which are present in the semen, are synthesized from the putrescine. And coming to the cadaverine, it is a product due to decarboxylation of the amino acid lysine. So lysine on decarboxylation gives cadaverine, a biogenic amine. So here you can see lysine by decarboxylation in the presence of enzyme lysine decarboxylase by removal of carbon dioxide is converted to cadaverine, a biogenic amine. So cadaverine. So important role in cell survival at acidic pH. The important aspects of cadaverine. It plays important role in survival at acidic pH. It protects cells that are starved of inorganic phosphate. It helps in supplementation of inorganic phosphate. So it protects the cells that are starved of inorganic phosphate. So these are important aspects of cadaverine. And coming to thyramine, it's a product by decarboxylation of tyrosine, removal of carbon dioxide from the tyrosine, thyramine. Okay. So tyrosine, the action of the enzyme tyrosine decarboxylase by the removal of carbon dioxide leads to the formation of thyramine, which is an important biogenic amine. So coming to the actions, it is vasoactive amine that regulate blood pressure, the thyramine, and it leads to cerebral vasoconstriction and subsequent rebound vasodilatation that causes a migraine attack in the suscepted patients. Okay, so this is the important aspect. Mainly, it will regulate the blood pressure. That is the important aspect of the thyroid, which we are getting from the tyrosine. Okay, so we had seen the different biogenic amines. So, what are the biogenic amines? The important biogenic amines: dopamine, serotonin, and this thyramine, putrescine, cadaverine, and this will recollect all the things. So histamine, dopamine. So dopamine and serotonin. We know dopamine we are getting from the tyrosine. Serotonin we are getting from the tryptophan. It's a very small topic, so remember. Histamine we are getting from the histidine. And degradation and you can remember. And you have to remember the important aspects. This all you had already seen in the physiology. And putrescine we are getting from the ornithine. And cadaverine we are getting from the lysine, or by decarboxylation of amino acids. Cadaverine from lysine, tyramine from the tyrosine. Okay, and remember the important aspect of all the biogenic amines, important aspects of all the neurotransmitters, and also all the biogenic amines. So we had seen all the neurotransmitters which we are getting from the amino acids, and the biogenic amines which will synthesize only from the amino acids. So all those we have seen. So coming to the conclusion of the biogenic amines, these biogenic amines are stable to thermal processing. Their presence in finished canned products is a good indicator that the raw material was spoiled prior to heating or retorting. Okay, that means they are very stable to the thermal processing. Okay, so in finished canned products, they can act as good indicator to check whether the product is spoiled or not before heating. That is an important aspect of biogenic amines in general. So here we had finished the neurotransmitters and biogenic. Dopamine, serotonin, histamine, tyramine, and putrescine and cadaverine. And you have to remember the amino acids which they are producing. Okay, tyrosine, tryptophan, and tyramine also tyrosine, lysine, histidine, ornithine. So coming to the aminoacidurias. So what are aminoacidurias? By name itself, we can say what are aminoacidurias. So excretion of amino acids in the urine are known as aminoacidurias. So when excretion in urine occurs for any biochemical substance, when it is excreted in the urine, so it is excreted in the urine when there is excess in the blood. When the amount of any biochemical substance is increased in the blood, then it will be excreted in the urine. Okay? For example, glucose. If glucose is increased in blood, hyperglycemia, then it leads to excretion of glucose in the urine. Okay? So, what is the other condition in which glucose is excreted in the urine? One is when the glucose is increased in the blood. That means when there is hyperglycemia, it leads to excretion of the glucose in the urine. And what is the other condition which we had discussed in the case discussion also? What is the other condition in which glucose is excreted in the urine? Glycosuria. The one reason is hyperglycemia. The other is renal glycosuria. So when there is any defect in the kidneys for the reabsorption of the glucose, it leads to excretion of glucose in the urine. So same thing happens in the aminoacidurias also. There can be two important causes. One is when the amino acids are increased in the blood, then it leads to excretion of amino acids in the urine. And the other thing is when there is any defect in the kidneys, then it leads to defective reabsorption of the amino acids, which in turn leads to excretion of amino acids in the urine. Okay. Then when the amino acids are increased in the blood, what causes increase of amino acids in the blood? So generally, the amino acids are increased in the blood when there is any defect in the metabolism of amino acids. When there is any defect in the metabolism of proteins. In the defect in the metabolism of proteins, in general, number of amino acids can be increased. Any amino acid and any number can be increased. And when there is any defect in the individual metabolism of the amino acids, metabolism of the individual amino acids, it leads to specific aminoaciduria. Okay, that means specific amino acid is excreted in the urine. So these are the important aspects of amino acids, aminoacidurias that we are going to see. So aminoacidurias, what are aminoacidurias? Aminoacidurias occur when the urine contains abnormally high amount of amino acids. So this can occur when there is a protein metabolism disorder or individual amino acid metabolic disorder. Okay? So in that cases, the amino acids will be increased in the blood and which in turn they will be excreted in the urine. So generally in healthy kidneys, the renal tubule reabsorbs 95% of the amino acids. So amino acids after getting filtered, the 95% of amino acid will be reabsorbed before the excretion. So if 5% filtered load is detected in urine, it can be considered as aminoacidurias. Okay? So in normal healthy kidneys in a healthy person, so after the filtration of amino acids, the number of amino acids are released during different metabolisms of protein and metabolism of amino acid. So all these amino acids are present in the blood in general. In general only, some amount of amino acids will be rotating in the blood. So these will be filtered in the kidney and some part will be excreted. So in a normal healthy kidney, 95% of the amino acids are reabsorbed and again they are released into the blood and they will be utilized for different other metabolic purposes. And 5% will be excreted in the urine in general. Okay? Out of every 100 amino acids released during the metabolic turnover, 5 amino acids will be released in the urine. If more than 5 amino acids, that means more than 5% of amino acids are detected in the urine, then we can term it as aminoacidurias. Mostly more than 10%, we can clearly tell that there is aminoacidurias. The person is suffering from the aminoacidurias. Okay. Then what will we be doing? After we know that there is aminoacidurias to that person, then what we will do? We should know which amino acid is being excreted. Whether all the amino acids is excreted or only particular amino acid is being excreted. For that, what we will do? How we will separate the amino acid and how we will detect which amino acid is being excreted. We had already discussed in the previous session, the practicals also. The chromatography. So by using chromatography, by passing the run on the chromatography, we can see whether all the amino acids are increased or only a particular amino acid is increased. Okay, you know the technique of amino acid. A normal mixture of all the amino acids is also kept on the run, and the individual amino acids are also kept. And the urine mixture is also kept. The person urine is also kept on the run. Okay, chromatographic run. Then what happens is all the amino acids will be moving to their extent in the chromatographic run. In the patient sample, the amino acids present in the patient sample will also run along with the individual amino acid sample amino acids. Okay, reference amino acids. Then by seeing the distance traveled by the amino acids on the paper chromatography, we can assess which amino acids are present in the urine. Okay. And after that, we will be quantifying the amino acids. So in this way, aminoacidurias can be detected and aminoacidurias can be assessed. So coming to the types of aminoacidurias, there are two important types of aminoacidurias. That is overflow aminoaciduria and renal aminoaciduria. We had already seen overflow aminoaciduria. The meaning itself, we can say overflow means when there is any increase. If suppose we take a bucket of water, if the water is increasing in the bucket, then it will overflow. In the same way, if the amino acids are increased in the amino acid pool, it leads to excretion of amino acid in the urine. So that's why it is named as overflow aminoaciduria. This is mainly due to defect in metabolism of individual amino acids or defect in overall protein metabolism. And the second type of aminoaciduria is renal aminoaciduria. This is due to defect in transport system and tubular damage. That means renal tubular damage. Okay? It is due to the renal aminoaciduria is due to just like renal glycosuria. The renal aciduria, aminoaciduria is due to defect in the renal transport system or defect in the renal tubular damage or damage to the renal tubes. Okay? In both cases, it leads to renal aminoaciduria, even though the metabolism of amino acids is normal. So in both these cases, the amino acids can be excreted. So that's why it is broadly classified into overflow aminoaciduria and renal aminoaciduria. Okay. So the best example of overflow aminoaciduria is the common example, the important example is we have studied a lot. It is phenylalanine, okay, phenylketonuria. So that is, we know there is defect in the engine. Due to that, the phenylalanine will be accumulated, which leads to excretion of phenylalanine. Phenylalanine hydroxylase deficiency. So phenylalanine is not metabolized, and phenylalanine is in the blood, it is excreted in the urine. So that is the best example for the overflow aminoaciduria. So coming to the renal aciduria, what is the best example for renal aminoaciduria that we had already covered? In the tryptophan, Hartnupp's disease, okay, there is defect in the transport system due to which the tryptophan will be accumulated and it is excreted. So they are the best example. So coming to the overflow aminoacidurias, this occurs when there is increased amino acid in blood due to metabolic defect. So sodium amino acid co-transporter channel is also affected in overflow aminoacidurias. Okay. So here the main thing is metabolic defect of amino acids, which leads to accumulation of the amino acids in the blood, which leads to overflow of the amino acids, which leads to excretion of amino acids in the urine. Next, coming to the renal aminoacidurias. So the defect in reabsorption of amino acid by kidney due to tubular damage or defective transport system. Okay. The main thing here that we have to remember is in renal aminoacidurias, the defect is in the kidney. It can be defect in the tubular damage, or it can be defect in the transport system inside the kidney. Within the kidney, there is transport system for different amino acids. So if there is any defect in the transport system, or if there is any defect in the tubular system of the kidney, it leads to tubular aminoacidurias. Even though there is normal amino acid metabolism in the body. So coming to the causes of aminoacidurias, the first one is congenital. Okay, that is enzyme defect. Congenital is the most common cause of the aminoacidurias. The congenital is mostly due to enzyme defect, like phenylketonuria. And renal cause. So reabsorption failure due to tubular damage, there can be reabsorption failure can occur. Okay, this causes to aminoacids, because 95% of the amino acids can't be reabsorbed when there is reabsorption failure. Okay? That leads to excretion of more than 5% of the amino acids present in the blood. So this is aminoaciduria. So secondary to liver disease. In some liver disease, secondary to liver diseases also, we know most of the metabolisms are correlated with the liver only. Most of the metabolism, amino acid metabolism, protein synthesis, all these things take place in the liver only. So if there is any liver disease, then it disturbs the protein metabolism and amino acid metabolism, which leads to accumulation of the amino acids, which finally leads to the aminoacids. Okay, excretion of amino acids. And the next cause is defect in transport protein in renal tubule. We know different transport proteins, transport system is necessary for different amino acids in the renal tubules. Okay. So we know we had already seen about the transport system of tryptophan. So this leads to Hartnupp's disease. And next cause is damage to the kidney tubules. Fanconi syndrome is a syndrome in which there is damage to the kidney tubules directly. So that leads to defect in the reabsorption. The reabsorption defect can occur due to overall damage to the kidney, like the second one, and it can occur due to damage to the kidney tubules only, like in Fanconi syndrome. So if you see overall this, the congenital is nothing but it comes under overflow aminoacids, and all the other are renal. Okay, except this liver, this second one, this third one, this fourth one, and fifth one. All these come under renal aminoacids. And secondary to liver diseases, it also comes under overflow aminoacids, but it is not directly due to the metabolic defect. It is due to the site of the metabolism. The defect is in the site of the metabolism, the liver, which leads to increased amino acids, which leads to excretion of amino acids in the urine. Okay. So these are the causes. So the types are the overflow and the renal, and causes are can be congenital and renal and the secondary to liver disease. So these are the different aminoacidurias, common aminoacidurias. Any excretion of any amino acid in the urine more than 5% can be considered as aminoacidurias. But these are the common aminoacidurias. Phenylketonuria, the enzyme defect is phenylalanine hydroxylase, and tyrosinemia, hyperthyrosidemia type 1. The enzyme defect is fumarate esteroestane hydroxylase. Alkaptonuria, this is also an important disease due to enzyme defect homogentisate oxidase. And homocystinuria due to the defect in the enzyme cystathioline beta synthase. And homocystinuria due to defect in methyl transferase enzyme. And homocystinuria type 3, the defect in the enzyme reductase. And histidinemia, the defect in the enzyme histidase. Most of these are congenital, and most of the examples given here are overflow aminoacids. Okay, because all these are due to enzyme defect and metabolic defect of the amino acids. And most of the cause of this enzyme defect is congenital only. And clinical manifestations for different amino acid residuarias are different. And most common clinical manifestation for most of the congenital disorders, you remember, for most of the congenital disorders, most of the metabolic disorders, the common clinical symptom is mental retardation. Okay? Because due to accumulation of different biochemical products, it affects the brain. Most of the biochemical substances will accumulate in the brain, or can indirectly affect the brain. So that's why the common symptom, the common clinical manifestation is always mental retardation. Okay? Even for our porphyrias, or even for many of the metabolic disorders, the common symptom is mental retardation. Okay, apart from that, we'll be seeing the seizures, arthritis, and this renal and hepatorenal damage. All these are seen as the clinical manifestations of the aminoacids. Coming to the symptoms, the common symptoms that we see when amino acids are accumulated are pain, diarrhea, headache, back pain, constipation, and visual change. So these are the symptoms that we see in the aminoacidurias due to accumulation of amino acids in different parts of the body. When coming to the diagnosis, blood test, cystitis test, cystinuria, and urinary tract infection, which is common in aminoacidurias, and kidney test, urine protein test to see whether the kidneys are working properly or not, and genetic test to see whether there is any enzyme defect. Due to congenital enzyme defect, the aminoacidurias can occur. The most common test that we do for diagnosis is urine test only. Okay, chromatography, urine test, quantitative and qualitative estimation of the amino acids is done. That is the first thing. And to see the underlying cause, we will do all these blood tests, cystitis test, and renal test and genetic test to see the underlying cause. Okay, this is the as the diagnosis of aminoacidurias. Coming to the treatment of aminoacidurias. So we know the amino acids are increased in the blood and they are being excreted in the urine. So treatment depends on the underlying cause. When the underlying cause is treated, then it can be subsided. So amino acids are reduced in the body. So by taking different medications or different conservative care, the amino acids should be reduced in the body. That is the primary line for the treatment. And underlying cause should be treated. So dietary restriction, as amino acids are increased, dietary restriction of particular amino acids to be done. The amino acids which are increased, the dietary restriction of that particular amino acid should be done. And more liquids in the diet should be taken. When more liquids are taken, it dissolves molecule and reduces their concentration, and kidneys reabsorption will be increased. The reabsorption capacity of the kidneys are increased, and obviously it will reabsorb the excess amino acids. Okay? As the complex molecules are reduced, the kidneys will obviously reabsorb more amino acids. So that is the advantage of taking more liquids in the diet. And medication. So medications help in alkalizing the urine, which allows kidneys to reabsorb excess amino acids easily. Okay? So when the urine is alkalized, it will absorb the acidic amino acids easily. So that's why medications are taken to alkalize the urine. And dietary restriction to decrease the amino acids, and liquids to decrease the excretion, and medication to decrease the excretion by reabsorption. So this is the aminoacidurias. So aminoacidurias are nothing but excretion of amino acids in the urine. It can be renal aminoacidurias or overflow aminoacidurias. The overflow aminoacidurias are due to metabolic defect, the amino acid metabolic defect or protein metabolic defect, and renal aminoacidurias are due to defect in the kidneys. Whether it can be defect in the renal tubules or defect in the transport system in the kidneys. Okay. Coming to the causes, the aminoacidurias can be congenital due to enzyme defect, or it can be due to secondary to the liver diseases, which is the site for most of the amino acid metabolism. So in these both cases, the amino acids will be increased in excess urine. So these come under overflow aminoacidurias. And the other causes are the renal defect in which the reabsorption is affected, and the renal tubular defect in which the reabsorption is affected, and defective renal transport system for the amino acids. So in all these three cases, the renal defect, the amino acids will be excreted in the urine. So these come under renal aminoaciduria. Okay, and different symptoms we will get due to accumulation of amino acids in different parts of the body, and the diagnosis is mainly done by assessing the urine to see whether the more than 5% amino acids are present in the urine or not. To see whether more than 5% are present in urine or not, we have to estimate the amino acids present in the blood also. So blood testing is also necessary. And to see the underlying cause, and urine examination and chromatography is done to assess the amino acids present in the urine. And apart from that, the renal damage should be estimated, the renal tubular assessment should be done. So renal testing and genetic testing should be done to see the underlying cause for diagnosis and to see the underlying cause, underlying metabolic congenital defect. And coming to the treatment, diet restriction to decrease the amino acid, more liquid to increase the reabsorption by decreasing the complex molecules, and medication to increase the reabsorption by alkalizing the urine. So this is the treatment of aminoacids. So today we have seen the amino acids which are acting as neurotransmitters, the amino acids synthesizing the biogenic amine, and the amino acid defect leading to the aminoacidurias. Okay, so this finished the class. So thank you and all the best. Hope everyone is clear with all the aspects. Okay, right.